Now, what has changed? Just to give you an idea, one thing that has changed is that transplant has become better. That transplant has a number of important changes in the ways we do transplant, in the medications we give to prepare the patients for transplant, what we call the conditioning regimens that make it safer. There's also advances in supportive care, meaning blood transfusions are safer than 10 years ago, because many patients need blood transfusions during their transplant. Antibiotics, and I'll come back to that a bit, antibiotics, antivirals have become much better. Diagnostic methods have improved for diagnosing and preventing complications. As a result, we now take on much more older patients than we used to. Back in 1987 to 1993, the data I show here are from an international registry from patients transplanted across the world. Back in 1987 and 1993, most patients were between 21 and 40. A couple were between 41 and 50, about 20%. Very, very few patients over the age of 50 were ever transplanted. Nowadays, or at least between 2001 and 2007, you see how these bars have leveled off, how 20% of the patients are now over 50 and 10% are over 60. In my center, half of the patients are over 55. Our average age is 55. And I think that's rapidly changing. You know, I think this is more 2001 than 2007. I think if you would repeat this now, we take on a lot more older patients. Why is this important? Because many of the diseases that I talked about, that are the indications for transplant, acute leukemia, is much more common in patients. The average age is 60. So we used to offer this treatment for younger patients. That was a small fraction of the patients with leukemia. But now we can at least offer it up to age, our oldest patients at the University of Chicago was 71. That being said, we become more selective in older patients. So when we quite routinely do this now up to age 65. In older patient groups, we end up being, we consider it, there's no longer an age limit. We used to say, listen, over 50, no way, or over 60, no way. We no longer think like that. We think, listen, we will look at the pros and cons. We will assess how healthy you are, how easy it is for you to go through. As we all age, we all get more and more health problems. It's not just, a young person who has leukemia. Leukemia is the only problem that person has, and a person in their 60s often has some other health problems that we have to take into account. But we can do this now, and we often do this quite successfully. And you can see that here, a big problem, and we can talk about that more in detail. But a big problem with with donor transplant is that it doesn't always go well. There are problems, there are serious problems, serious complications, and there are people who die of complications. But here you see that in 2005, 2006, that the patients who die within the first 3 months, it's for most groups around 10% or less, which is still, I don't underestimate that. It is still a huge thing to go through and a big decision to go through. That being said, 10, 15 years ago, this would have been much, much higher. There's a couple of groups here who have higher risks, up to 20%. These are patients with very, very, very advanced disease, and AML, acute myelogenous leukemia, that has not responded to any other treatment. Those patients remain at high risk. Let me skip this. This just shows how for CML the indication has disappeared. This gives you, and I don't want to show too many of these slides, I have a couple here, but it shows how transplant is a procedure, one of the dilemmas we face with the patients with acute leukemia, which is probably the most common indication, is when to offer this. Here we have an excellent treatment that can cure patients, but it cures patients more if the patients are healthier, if we offer the transplant early in the course of the disease. Now, those same patients, and that means in first remission. I don't know whether some of you must be familiar with this term, but we treat patients with chemotherapy, with acute leukemia. They go in remission, meaning we can no longer detect the disease. The disease is, we do a bone marrow test in the case of leukemia, or we do CT scans in the case of lymphoma, and we can no longer find the disease. Does not always mean they're cured. I mean, in some cases it's the first step toward cure. And then we have this dilemma: should we go on with chemotherapy only? And some patients, it's clear that they will benefit only from chemotherapy and will have a high chance for cure. Other patients, it's not so certain, and we have this dilemma: should we offer a transplant now, which is perhaps a bit more risky, but if successful, we cure up to 60% of patients early on, or should we give them a chance with chemotherapy, and perhaps the cure rate with chemotherapy is only 30%, but it's less risky as far as immediate complications. Those patients who get chemotherapy and then the chemotherapy doesn't work come back later on with advanced disease, and then we can still do a transplant, but the later we do a transplant in the course of the disease, the less well it works. So with every... To me, this is, 60% of our work is helping the patients make that decisions and trying to, in every individual case, decide what's best for the patient. And cannot talk much more about that without going into much more detail, but that kind of trying to put this in perspective. Now, another big issue is, what do we do for the patient who doesn't have this fifth sibling? And that can be 1 out of 10 siblings, that can be 1 out of 2 siblings. I have patients with 2 siblings, and all 3 have the same HLA type, and all 3 are donors for one another. And then I have families with 12 children, and nobody for, 3 of them match, but the patient who has leukemia does not match with anybody. It's a chance thing. And there's quite a few patients that or who don't have sibling donors, and as family sizes shrink worldwide, it's becoming more and more of a problem.